Today I'm going to be discussing sickle cell disease, which is the first disease to have been characterized at the molecular level with the mutation leading to the abnormal hemoglobin defined. The talk will discuss the pathophysiology, the genetics of the disease, the role of newborn screening in identifying patients and preventing complications. I will be discussing specific complications including infection, painful crisis, and acute chest syndrome, but will not discuss many other important complications such as strokes in the interest of time. The therapeutic approaches, including hydroxyurea, transfusion, and bone marrow transplantation, will be described, and I will touch upon new therapies such as gene therapy. Now, sickle cell disease is the result of a single amino acid substitution in position 6 of the beta chain of hemoglobin. This is because of a single base mutation. The majority of patients have homozygous sickle cell disease or HBSS. However, the phenotypic disease, sickle cell disease, can be the result of several genotypic variants, the most common of which is HBSS, but also common in our part of the world, it's the hemoglobin S beta 0 and beta plus thalassemia, which I will discuss further. And in some parts of West Africa, patients with sickle cell disease have co-inherited an abnormal hemoglobin, hemoglobin C, that also leads to sickling when mixed with sickle hemoglobin. So a single amino acid substitution is responsible for this disorder. Now, what this leads to is to a hemoglobin that, upon deoxygenation, and can polymerize. Now, this polymerization occurs in two stages. First is the formation of a critical polymer of about 30 hemoglobin tetramers shown in the upper part of the slide, and this is a reversible reaction, but it's favored by high temperature, acidic pH, um, high hemoglobin concentration, and once the critical polymer is formed, it will lead to further polymerization with the fibrils of hemoglobin precipitating within the red cell. Now, the critical polymer formation can be inhibited by diluting the hemoglobin concentration, but more importantly, by certain factors, including the presence of fetal hemoglobin, which is an important modifier of this disease, and patients who have higher fetal hemoglobin do better. We also have agents that will lead to increase in fetal hemoglobin, and this can explain why they do better. Now, the molecular structure of sickle hemoglobin was described, and as you can see here on the left-hand side of this picture, you can see how the hemoglobin tetramers align with hydrophobic areas outside, leading to the formation of these polymers seen in the middle of the figure, and these polymers further precipitate within the red cell, leading to the change in shape of the red cell from the usual discoid erythrocyte shape to a sickle shape. And all of you know what a sickle is, a minjal. It's an instrument used in agriculture. Now, these cells, once they become sickled, have a shortened lifespan, hence hemolysis. Sickle cell disease is a hemolytic anemia, and also they will lead to interactions with the endothelium and vasoocclusion. And this can be seen in this slide, the single base substitution, single amino acid substitution, leading to an abnormal protein, cellular changes, increase in cellular adhesion, to the endothelium, recruiting white cells and platelets, leading to oxidation, inflammatory changes, activation of coagulation, and end organ damage. I particularly like this slide, which shows the multiple physiologic pathways: hemoglobin S chelation, RBC sickling, and hemolysis in one side of this diagram, activation of coagulation, in adhesive interactions, red cells, white cells and red cells, white cells, red cells, and platelets, and interaction with the endothelium, as well as inflammation. You can also see that these therapeutic approaches can take advantage of the pathophysiology. Anti-selectins and anti-signaling molecules are going to impact the adhesive interactions seen in the upper side of the modified diagram. Prevention of sickling, and we have agents now that prevent deoxygenation of the red cell, and this will lead to a decrease in hemolysis. The activation of coagulation can be attacked through antiplatelet agents, and cytokine production and inflammation can be attacked with anti-inflammatory agents. So far, we have had agents like hydroxyurea that increase fetal hemoglobin and inhibit polymerization. We also have agents that inhibit adhesion that are in clinical function. Now, discussing the genetics of this disease, a little bit of history. In 1910, Herrick and Iron described the sickle-shaped red cells in the blood of Walter Clement Noel, who was a dental student from the Caribbean studying in Boston, who had this hemolytic anemia and suffered pain crisis. These sickle cells were shown to acquire this shape upon deoxygenation in 1927, and about 22 years later, Linus Pauling demonstrated that patients with sickle cell disease had an abnormal hemoglobin by electrophoresis. He showed that the parents had a mixture of normal and abnormal hemoglobin, and went on to describe the molecular structure and define the amino acid changes in this hemoglobin. Now, the genetics were further elucidated in 1951, where it was found that sickle cell disease, even though both hemoglobins are expressed, is manifest sort of as a recessive disorder when two parents were carriers have offspring. 1/4 have a probability of being homozygous for hemoglobin SS. 50% have the probability of having a trait, and another 1/4 have the probability of being completely uh, normal. Now, in 1960, Max Perutz developed a 3D model of the sickle hemoglobin molecule that allowed us to define that fibril formation from the different tetramers. Now, as I mentioned, there are multiple genotypes that lead to the sickle cell phenotype: homozygous SS, SC disease, S beta 0 thalassemia, S beta plus thalassemia. Now, patients who have trait have slightly more normal hemoglobin and are really, for the most part, completely asymptomatic. Now, if you look at this table, and it's also in one of your handouts, this is important because in the clinic, this is what allows us to determine what is the genetic basis of the disease in a particular patient. Now, the very bottom column shows very bottom row shows homozygous sickle cell disease, where patients have 85 to 95% hemoglobin S. They do not have any abnormal hemoglobin. They do have variable levels of higher fetal hemoglobin, and they have a normal level of hemoglobin A2. Now, second row, which is beta thal minor, and you have studied this in thalassemia, patients have mainly normal hemoglobin A, but they have high hemoglobin A2. So this is beta thal minor, and if somebody with beta thal minor has offspring with a patient with sickle cell trait shown in the column in the row underneath, where they have slightly more A than S, you can have a patient who has either S beta plus thal with a small amount of hemoglobin A, 5 to 30%, high hemoglobin A2, elevated hemoglobin F, and the majority being S. Now, if the other parent has a mutation for S beta 0 thalassemia, as part of the beta thal trait, then the patient is going to have zero normal hemoglobin A, 80 to 90% hemoglobin S, uh, elevated fetal hemoglobin, HbF, and more than 3.5% elevated hemoglobin A2. Now, of course, if there is another abnormal hemoglobin, this is evident on electrophoresis, and in this case, the patient had a mixture of hemoglobins S and C, and therefore had hemoglobin SC disease. Please look again at this in your handout, as this will be important for you when you reach the clinical years. Also, they like to ask these questions on boards. They give you an electrophoresis and ask you what the diagnosis is. So, to recapitulate, there is a single base substitution that leads to a single amino acid substitution, valine for glutamic acid in position 6 of the beta chain, leading to an abnormal hemoglobin, which under conditions of fever, hypoxia, acidosis, dehydration, will go into polymerization and sickling. This will lead to a shortened red cell survival or hemolysis with the ensuing anemia, jaundice, gallbladder stones, etc. Also unique to sickle cell among all the other hemolytic anemias is vasoocclusion that will be manifest as painful crisis, acute chest syndrome, strokes, eye damage, multiple other problems that we will touch upon later. And now, the consequences of sickling, again, hemoglobin polymerization, increase in inflammation on the left hand side of this slide, adhesion of WBC to the endothelium, vasoocclusion, hemolysis, activation of coagulation, red cell dehydration, and membrane damage. Now, it's important to note that the complications of sickle cell, vasoocclusion, hemolysis are common across the lifespan, but certain complications are more common in children, like infection, splenic sequestration, and infarctive strokes, whereas others are more common in adults. In between, we have the vasoocclusive episodes, VOE in this slide, acute chest syndrome, ACS, gallstones, priapism, iron overload, and a plastic crisis due to parvovirus infection that are common between the two. Now, we will now be discussing the role of newborn screening in preventing complications in patients with sickle cell disease in the newborn period, in the first year of life. The goals of newborn screening are to decrease mortality in the first year of life, and mortality is usually very high, up to 38%, as these babies are born with high fetal hemoglobin and they have no symptoms other than risk for infection. And if the parents and the doctors are not aware that the baby has sickle cell disease, the fever will not be handled appropriately, and thus there is an increased risk for mortality. These patients need prompt attention to fever and immediate institution of antibiotic therapy. In addition to risk of infection, there are other early symptoms that the families need to be educated upon. These include dactylitis and sequestration or trapping of the spleen in the red cells in the spleen. As far as infection complications are concerned, these are the most important. Are the most important causes of morbidity and mortality in infants as young as 4 months. This is due to splenic dysfunction. As I mentioned, pneumococcal sepsis is common, and patients need to be immunized and put on penicillin prophylaxis. And if they have a fever, there needs to be prompt attention to fever. And this is why newborn screening is important, because it has decreased the mortality from, as I showed you, 38% to almost zero in the first year and in the first uh, 3 to 4 years of life. And in our country, unfortunately, we do not have that, but newborn screening is done on all four hemoglobinopathies, is done on all newborns in all states of the US and in most Western European countries and in most states of Brazil, and it's becoming more and more common all over the world. Now, the infectious complications are not confined to the first year of life. Patients have strep pneumonia, they can have Haemophilus influenza. Now, there are vaccines for this, potent immunizations. Salmonella species can be an important source of infection, and Salmonella osteomyelitis can happen in patients with sickle cell disease, and you can have other infections like Staph aureus, Mycoplasma, and Chlamydia are common, and parvovirus leading to marrow suppression. As in most other hemolytic anemias, this can be associated with aplastic crisis. Now, other acute episodes in sickle cell disease include acute pain crisis, acute chest syndrome, pneumonia, septicemia, priapism, and these are what drives patients, children, and adults to go to the emergency room. I'm going to be discussing with you pain crisis because this is very important. Pain is the hallmark of sickle cell disease. These episodes usually are multiple episodes, and the more episodes a patient have, the higher risk of early death. In young children, they can have dactylitis, swelling of the hands and feet, and we know that we can predict some risk factors for these patients. Patients with higher hemoglobin have higher risk for pain crisis. Older patients have higher risk. Patients who co-inherit alpha thalassemia have higher risk, but I am not going to go into the details about this. For the most part, it's important to predict. Usually, these are recurrent acute episodes, but they can also be chronic pain. Now, the episodes have to be treated acutely with non opioid analgesics, opioids for severe pain, but hydroxyurea and transfusions can prevent the recurrence of pain crisis. I'm going to talk about this in a little bit more detail later. Now, the person who did most to study pain in sickle cell disease is an AUB graduate, Dr. Samir Ballas, and he defined the 4 phases of a painful vaso-occlusive episode. And I mentioned this just out of interest. You don't necessarily need to uh, go into the details about this, but there is a prodromal phase, an initial phase, an established phase, and then the crisis resolves. And up till now, there is very little we can do to manage this pain crisis except for hydration, give these patients analgesics, and believe them because the crisis does take time to resolve. Now, many patients, and this is another contribution of Dr. Ballas, have chronic pain. They have a chronic pain syndrome. And in the US, because most patients are Afro Americans, these patients come in and they were labeled as drug seeking or drug addicts. In fact, the rate of drug addiction among patients with sickle cell disease is lower than that of the general African American population. Still, the use of opioid analgesics is high in the US. In fact, it's higher than in other parts of the world, but this does not mean that the patients are drug seeking, but it means that they need better approaches to their pain. Now, of course, on top of the chronic pain, there could be chronic exacerbations, acute exacerbations, shown here as the blue triangles. This is the contribution of AUB graduate and a good friend, Dr. Samir Ballas. Now, how do we manage these painful episodes? And here, as young physicians, I want to impress upon you the need to believe these patients. There is a lot of bias. Patients with chronic pain, people say, oh God, this patient is always in the ER with pain. This cannot be true, but it is true. And because of this bias and stigma, sickle cell patients who present to the ED experience significantly longer waiting times when compared to other patients with pain. For example, somebody coming in with a renal colic. And this is even after accounting for the assigned triage level and acuity. So somebody with very bad pain with sickle cell will be left aside to wait for a longer time. And this is because often patients come to ED where the providers have very little experience with sickle cell disease. That's why, as experts, we provide the ED with guidelines, and this makes the management better. And as I mentioned, there are barriers to effective pain management, would include the social-cultural factors and concerns regarding addiction or pseudo-addiction. But for the most part, believe these patients when they come into the ED, they are not addicted. You see, I have a patient who kept on coming in. He would come in every 2 to 3 months with an acute pain crisis. And somebody in the ED would say, he's addicted. I said, look, if he were addicted, he would be getting drug every day of his life, not coming in every 2 to 3 months because he decided he needs some morphine on that day. And morphine is really the best way to manage these patients. I don't, in the acute setting, I don't want to go into details about that. Now, another critical vaso-occlusive complication is the acute chest syndrome. This is a new pulmonary infiltrate involving at least one complete segment of the lung, and it's usually accompanied by chest pain, fever, tachypnea, and wheezing. And there will be hypoxia compared to the baseline. Now, in addition to this, acute chest syndrome can complicate admissions of patients for other reasons. If a patient is admitted because of pain, this patient, if not well taken care of, has a 30% chance of developing acute chest syndrome. And this is why we need to be careful not to over-sedate, not to overhydrate. Also, patients with sickle cell disease undergoing surgery have a high risk of developing acute chest syndrome. I'm showing you here one chest x-ray that shows in the right lower lobe a starting infiltrate, and this can very, very quickly progress. And the reason for this is again pathophysiology. If you look at this slide on the pathophysiology of acute chest syndrome, the causes can be infection, fat embolism from bones that become vaso-occluded, and vaso-occlusion in the lung itself. Now, the infections can be due to multiple organisms, chlamydia, mycoplasma, legionella. The fat emboli shown in blue on the right, these are the fat-laden macrophages that can go to the lung. But once this is set in place, there is a vicious cycle that develops. Uh, let's say there is infection, pneumonia, vasoocclusion, hypoxia, more vasoocclusion, and occlusion in the bones, and fat embolism, and so on. So this is really a serious complication. It is very serious because it's associated with increased mortality in the acute setting. And if you can see in this survival graph, the line in blue are patients with sickle cell disease, about 1,700 of them, who did not have acute chest syndrome. And the patients in green are 400 patients from the same cohort who had recurrent episodes of acute chest syndrome. And you can see that the patients who had recurrent episodes of acute chest syndrome um, had a worse survival. Now, I do not want to go into the acute management, but these patients need judicious hydration, blood transfusions, and of course, antibiotics to cover possible infections, including chlamydia, mycoplasma, strep pneumo, and so on. Now, because of the increased mortality with multiple recurrent episodes and the morbidity, it's very important to prevent recurrent episodes of acute chest syndrome. And here we have our three known therapeutic modalities: hydroxyurea, transfusion, and stem cell transplant. And all of them are effective in preventing the recurrence of episodes of acute chest syndrome, as has been shown in multiple studies. It's very important, though, the last point on this slide: multimodal pain intervention, with educating caregivers how to take care of a patient who is admitted for pain to prevent the occurrence of acute chest syndrome in the hospital. This is very, very important. I have a favorite story. One time I had a patient with sickle cell who was admitted to our hospital because of also having had congenital heart disease. He got fantastic surgery, fantastic repair, but in the post-operative setting, he was not breathing because of the pain and very rapidly went down. He was salvaged because a resident very promptly alerted the team. We came in, we gave him more blood, made sure that he did intensive spirometry, breathed, and opened his lungs. Now, I want to show you one slide, which is I'd like to show which are the treatment options for sickle cell disease. And most important, and what is really responsible for the improved survival in children, are the preventive measures. As I mentioned, newborn screening, the institution of penicillin prophylaxis to prevent deaths from pneumococcal sepsis, vaccinations, TCD. TCD stands for transcranial Doppler monitoring. We can now detect people who have abnormal cerebral blood flow and are at risk for strokes and put them on transfusions. We need to screen patients for pulmonary dysfunction and other end organ dysfunction, provide them with folic acid supplementation, educate the families, and of course the specific therapeutic options, which I'm going to describe next: the hydroxyurea, transfusion therapy, and hematopoietic stem cell transplantation. uh, Hydroxyurea is one of the drugs that can increase fetal hemoglobin. And in this slide, you can see the effects of hydroxyurea. It is a urea molecule that has a hydroxyl group replacing one of the hydrogens. And it has an impact on erythroid progenitors, leading to higher fetal hemoglobin production by multiple mechanisms. It also impacts the myeloid precursors, leading to lower white count. And high white count is not a good thing in sickle cell disease. By preventing hemolysis due to increased fetal hemoglobin, it also leads to decreased number of reticulocytes, and reticulocytes in sickle cell patients are very, very adhesive. They have increased expression of adhesion molecules. Therefore, they are decreased in number and have lower expression of adhesion molecules after treatment with hydroxyurea. The erythrocytes, the red cells, are bigger, higher MCV, therefore they contain more water and the lower hemoglobin concentration. This is only inside the red cell. The actual hemoglobin goes up with hydroxyurea treatment due to decreased hemolysis, but inside the red cell, the hemoglobin is more soluble and in a larger water content with higher MCV, therefore less sickling. And hydroxyurea is also a nitric oxide donor, and this has an impact on endothelial cells. This is a slide from my friend Dr. Russell Ware showing the blood smears on patients with sickle cell disease who were treated with hydroxyurea, and you can see that in the left hand side there are many of these long abnormally shaped sickle red cells. This under treatment with hydroxyurea, these cells disappear, and on the right hand side, the smear becomes almost completely normal. So, sickled red cells, abnormal smears, like the cells seen in Walter Clement Noel, the dental student from the Caribbean with sickle cells, and on the left hand side, under treatment with hydroxyurea, the smear looks almost normal with normal erythrocytes. And as I mentioned, the risk factors that were identified for for higher mortality in sickle cell disease include lower fetal hemoglobin, multiple recurrent episodes of acute chest syndrome, renal failure, seizures, and high white count. And hydroxyurea increases fetal hemoglobin, decreases acute chest syndrome, and decreases white count. So has an impact on three major risk factors. And this is described here. This was showed in a randomized placebo-controlled study, which was published in 1995. It increased hemoglobin F, decreases rate of pain crisis, decreased rate of hospitalizations for pain or acute chest syndrome, and of course decreases white count. And there were a series of landmark publications that showed that hydroxyurea impacted both the acute problems and led to decreased mortality and morbidity in patients with sickle cell disease. Now, as an example of impact of hydroxyurea on mortality, our colleagues in Athens looked retrospectively at their patients, and they had treated only severe patients with hydroxyurea. They left the non-severe patients, they don't need treatment. They left them without hydroxyurea. When they looked 17 years later, they saw that the severe patients who were treated with hydroxyurea, shown here in the green curve, had better survival than the non-severe patients who were not receiving hydroxyurea in the blue curve. The 10-year survival probability was almost 100% for hemoglobin SS patients on hydroxyurea. The reduction in mortality was observed for both SS, S beta 0 patients, but not in S beta plus patients, because S beta plus patients do a little bit better anyway. And this was also reported in the American cohorts and the Brazilian group. So hydroxyurea has an important role in increasing survival in patients with sickle cell. Now, one of the problems that we have is that not all the patients get the drug, but that is another issue that we need to discuss separately. Now, these studies, needless to say, were done in adults, but is hydroxyurea effective in children? The baby hug study was a randomized placebo-controlled trial in children 9 months to 2 years of age, hence the name Baby Hug. And when we compare it here to the multi-center study of hydroxyurea, MSH, you can see that both were placebo-controlled studies, both had a relatively large number of patients. And if you look at pain, acute chest syndrome, and hospitalizations, they were all impacted in patients with sickle cell disease, whether they were young children or adults. And the differences were highly statistically significant. Less pain, less acute chest, less transfusion. Now, the babies, of course, had less dactylitis, but and this is because dactylitis, swelling of the hands and feet, doesn't usually happen in adults, but it is one of the earliest signs in children. And you can see here significant reduction in this. And the hospitalization in young children reached a very clinically significant result of decrease in hospitalizations. What happens with patients taking hydroxyurea, and I just want to show you these are results from the Baby Hug trial. You can see in red are the patients taking hydroxyurea, and in blue are patients on placebo. You can see that patients taking hydroxyurea had higher levels of hemoglobin, usually about a gram and a half. Patients taking hydroxyurea on the right hand side upper panel had a higher MCV, so larger red cells, and that they had significantly higher levels of fetal hemoglobin. Now, when you look at adverse events, I had also shown you this, but here is the cumulative probability of adverse events, and these are in young children. Red, less acute chest syndrome, upper left hand side, less pain, upper right hand side, less dactylitis, lower left hand sides, and lower transfusions. Now, transfusions. So transfusion is an important therapeutic modality for patients with sickle cell disease. When do we use? Discussing transfusions in sickle cell disease, transfusions are very potent and an important element in the treatment of sickle cell disease. And we can do transfusions in two ways. Either in the acute setting, somebody comes in, has severe anemia, they get a blood unit, they go on their way. Or in the chronic setting, they come in once a month for blood transfusions, like thalassemia patients. And there are indications for each: worsening anemia, acute chest syndrome, strokes are an indication for acute transfusions. The long-term management with chronic transfusions is primarily for the prevention of strokes, either in a child who has had a stroke or who is going to be at risk for a stroke due to high cerebral blood velocity by TCD. Intermediate is pregnancy. In pregnancy, we usually transfuse women for the duration of pregnancy. Now, in addition to acute versus chronic, there are two ways of doing transfusions in sickle cell patients: simple transfusions versus exchange. Simple transfusions, or what the British refer to as top-up transfusions, is just giving a blood to a certain level, to a hemoglobin of 10 or 11 in the acute setting. In exchange, we take blood out and give blood in. This can be done either manually or through a machine exchange. Now, they both have advantages and disadvantages. Exchange will expose patients to more units of blood, simple to less units of blood. Exchange requires venous access. A simple is a lot easier to do. The exchange prevents iron accumulation. Simple transfusion leads to iron accumulation, and patients who are on chronic simple transfusions will require chelating agents. But it's just for you to be aware of. In very bad acute chest syndrome, for example, exchange transfusion is the way to go. Do not go into the details of this. I just wanted you to be aware of this. So, treatment modalities, we said supportive care, antibiotics, hydration, hydroxyurea, transfusions. Now, there is only one way to cure sickle cell disease nowadays, and that's bone marrow or stem cell transplants. And this is a picture of our team harvesting a bone marrow in the OR. The donor is lying down. We pull marrow from the iliac crest and we put it in this bag. As you can see, it looks just like blood. Now, stem cell, we collect the stem cells from the peripheral blood. Usually, we do not do that a lot in sickle cell for multiple reasons. We prefer bone marrow, and it's also more fun. We get to go to the operating room. It is a curative treatment. Who do we do it on? What are the benefits? Now, sickle cell disease is a chronic disorder associated with significant morbidity and mortality. Stem cell transplant or bone marrow transplants are the only known curative modality for this disease, and this has been proven beneficial in preventing symptoms like acute chest syndrome, like stroke, like pain crisis, and in some cases it reverses end organ dysfunction. I'm going to show you the results from two large multi-center trials, the US and the French experience, and you can see here that both are associated with good survival, with excellent event-free survival. Initially, there was a high incidence of rejection, but we have overcome that, and the rejection rates are now way lower than 10 or 12%. And the problem that remains is that there is a limited availability of donors. Not all patients have HLA matched donors, and there are significant costs associated with it. Now, one important thing that we have learned from bone marrow or stem cell transplants is how to get cells to engraft. And this has become used now in gene therapy approaches. And this is not yet approved, but it's improving. How do we do gene therapy? Now, sickle cell disease is an ideal, and thalassemia are ideal disorders for gene therapy approaches. Basically, we get the hematopoietic stem cells here, not from a donor, but from the patient themselves. We put in a vector carrying the therapeutic gene, and this is transduced into the hematopoietic stem cells. We treat the patient with chemotherapy, which is usually significant but slightly milder than that used for bone marrow transplants. And then we reinfuse the stem cells. And the gene therapy for human beta globin gene disorders requires two things. One, we need to target the hematopoietic stem cells. We need to have control gene expression. We need to identify a gene transfer system. Animal models need to have been generated, and the vector need to be tested in ex vivo and then in vivo. And you can see here that we need to target only the hematopoietic stem cells, and that we need to have preferential expression of the gene in the erythrocytes. Now, there are multiple ways to do this. One can either correct the gene, and this is worked in vitro but not in vivo, and one could do several other things. One could do gene addition in the lower left-hand panel, where another gene is added to the abnormal sickle gene, and therefore you're going to get a situation where patients make a hemoglobin that's other than sickle hemoglobin, and people have done this successfully by adding another form of fetal hemoglobin, which I'll show you in a little bit, and this works very well. Or we can do gene editing approaches to look at increasing fetal hemoglobin induction in the red cells. So instead of adding an extraneous gene, we try to play around with the uh, mechanism of production of fetal hemoglobin, and this has already entered clinical trials to try and increase the endogenous fetal hemoglobin. But the only published yet has been one case where they put in a gene for an anti-sickling hemoglobin, and this gene was expressed, the vector was expressed in both peripheral blood and in the bone marrow. And you can see here the vector copy number being expressed, and you can see the hemoglobin concentration in the patients. The hemoglobin concentration here, the hemoglobin A went down, and the blue line, of course, this was transfused hemoglobin A. Then the hemoglobin S went up, but it was accompanied by the additional hemoglobin A, which is a modified hemoglobin A that interferes with sickling. And this patient did extremely well and ended up running a hemoglobin of 11 and was did not require further transfusions. This patient was being transfused for a stroke, um, yeah, and did extremely well and continues to do well. Now, these gene therapy protocols are getting better. As I mentioned, there are other agents in use, anti-selectins, agents that interfere with oxygen binding to the sickle hemoglobin, but I will not touch upon them today. So, in summary, sickle cell disease is a genetic disease associated with many potential complications, including pain and acute chest syndrome and strokes. Preventive measures, early detection, and ongoing patient monitoring are necessary steps to minimize and manage complications. Viable treatment approaches include hydroxyurea, transfusion therapy, and bone marrow and stem cell transplantation. Other patient centric interventions may also be required to achieve relief of complications for patients, and the future is bright as we have many new therapeutic modalities that are ongoing.